Hello and welcome to this author interview, Conversations with Dr. Bachner. This is Howard Bachner, Editor-in-Chief of JAMA, and I'm here with Derek Angus. Welcome, Derek.
Thank you very much, Howard. Glad to be here.
So for most people who are listening, they probably know, I've mentioned this before, Derek is a friend, a colleague, and an associate editor at JAMA. He's the Distinguished Professor and Mitchell P. Fink Endowed Chair, Critical Care Medicine, Professor and Chair, Critical Care Medicine, Professor, Medicine and Health Policy and Management, University of Pittsburgh Medical Center. But Derek, before we start, because we're going to focus on intensive care and COVID ID and patients in the intensive care unit, where did you get your accent from? I've asked you this before. It's one of the most intriguing accents that I've ever heard.
Well, I'm from Glasgow, Howard. Lots of people from Scotland. If you're usually from Glasgow, people think that you're hard to understand. I'm from Glasgow, but my father was a Highlander. My mum was from Edinburgh, and I've spent over about 30 years now bleeding black and gold on behalf of the Pittsburgh Steelers here in town.
Okay. Well, you and I did a live stream with ESICM on Saturday. Many different issues came up. So what I was hoping we'd do is segment this, walk through a lot of the clinical issues, then talk about your viewpoint, which I think is really complicated for people, optimizing the trade-off between learning and doing in a pandemic. And then towards the end, talk about what some of the struggles are going to be with the pandemic, ICU care, and individuals who are dying and their families. But let's start with the clinical issues. There's so many evolving issues. So you have 100 patients come into the hospital. It looks like about a third end up in the intensive care unit. That could be 20%, it could be 40%. Some of it may depend upon who's coming into the hospital. Some of it may depend upon how people use their intensive care units. But let's say about a third come into the intensive care unit. How do they do once they're in the intensive care unit?
Right. So as you alluded to, who's going into an ICU is slightly different around the world because of the total number of ICU beds and because of where a region is in the midst of its surge of cases. Any place that hasn't yet got too many cases may have already made the decision that when patients first hit the hospital, simply to conserve PPE, they're putting most patients, for example, in the ICU and cohorting them. So that one team can take care of multiple patients and go through less PPE. But let's assume that you're talking about the point where you're really using the ICU for the people who are presenting predominantly with severe respiratory distress. There's a couple of features about that. The first thing is every medical student remember there's two forms of respiratory failure. You either can't clear CO2 or you can't maintain adequate oxygen. First thing to know is that the predominant feature is that this is more of a hypoxemic acute respiratory failure. And so you're trying to manage patients who are struggling to adequately oxygenate. And I think everyone has heard on the media that this default has been to intubate the patients and put them on invasive ventilation. And then suddenly people are asking, now we don't have enough ventilators. So one of the questions that's coming up is, what can you do to avoid intubation in the first place? So obviously some people will respond well just to oxygen therapy. But obviously the concern is that people have failing saturations despite routine oxygen. And then the options are, would you try, for example, high flow nasal oxygen? And that's interesting because it's such high flow, it almost helps keep the lungs slightly inflated. So you're almost getting like a little bit of poor man's ventilatory support as well as oxygen. But it's very high flow and it may actually be aerosolizing viral particles.
Okay.
We have not worked out at this point exactly how safe that is, and people have different guidelines. But in general, if you're using high flow in a place where all the patients might be at risk, everyone's under PPE, then you should definitely rely on high flow. In a setting where there's not good PPE protection and there's both infected and non-infected patients, one would have to be slightly cautious about using high flow in everyone. The next option is to consider like a BiPAP mask or CPAP. So that's trying to provide ventilator support without actually intubating someone. And there's a lot of interest going around right now about whether that's actually being underused, because we're already getting reports that a significant number of patients are incredibly hypoxemic at first. But actually, if you just support them for a day or so, they may get through it. And young, otherwise healthy people may actually not even need to be intubated. There's even been anecdotal reports of doing things you normally only do on ventilated patients. So you put them on non-invasive, and then you have them lie on their abdomen. That's so proning, which takes advantage of west zones in the lungs by doing more preferential matching of where the air goes and where the blood goes. No one was doing that before a few weeks ago. This is one of the examples of ingenuity that is rising to the top as people try to think what to do. The problem with doing more aggressive CPAP or BiPAP is then what happens if the person fails? So you start them on CPAP, you put them off somewhere where they're maybe not under constant vigilance. And then if they start to get into trouble, it would be very concerning if you then missed an opportunity to intubate. So I think, especially given the ventilator crisis, especially given the fact that it could well be adequate for at least some subset of patients, a really important issue to get on top of is how safely can we use non-invasive ventilation. Everyone else, though, and indeed what many people are doing in many places, is just getting intubated if they appear to not be struggling. So then they go on if they appear to be struggling and cannot maintain adequate saturations.
Now, there's been some tension about early intubation versus waiting. Do you want to comment on that, or just not enough information?
Yeah, so you wouldn't wait on just oxygen if they're clearly failing, but yes, you could put someone on a helmet or a BiPAP mask or CPAP mask. You could even consider driving the CPAP at higher pressures than people have used normally, and that might work in a way that we would not normally have done in the past. The problem is that there's a general sense that if you let someone really exhaust themselves, and if they do so in a place, let's say you saw them in the emergency department, there was lots of people around, you made the decision to put them on CPAP, but then you move them to the floor where there's not as good observation on them, it would be terrible if they then had acute respiratory failure without someone able to immediately get to the bedside and intubate. So I think it's a really important question to ask, but we still need to think about the setting in which we do it, where there's no downside to waiting.
Now, there's been these reports about very rapid deterioration of patients. That's a bit unusual. Most people who are developing acute respiratory distress syndrome deteriorate over hours to days and not within an hour or so acutely. Do you have a sense of that?
Yeah, so Pittsburgh, we don't have a lot of cases yet, but already my intensivists are saying that they've actually noticed that. They've been watching someone and they grumble along, and then relatively quickly they get into a lot of trouble with hypoxia. And it's stimulating lots of debate about the front end of this disease and about whether there's something unique or particular about the way in which the virus, after it binds with the ACE2 receptor, whether it's inducing a very unusual or particular pathophysiology in the lungs, perhaps due to there are a couple of signaling pathways downstream from ACE2 inhibitors that could be causing some local problems that are accelerating, some sort of endothelial lesion or endothelial pathophysiology in the lung, which again may not be something that then goes on for days and days and days. It may be something that has an acute phase over a couple of days, after which people either self-resolve or maybe a subset might convert into a more fibrotic later pathway.
Right. I mean, there's been some reports that for the people who get intubated, they appear to stay on mechanical ventilation for a longer period of time than people's other experience with ARDS. But again, this is observational information. Do you have a sense of whether that's what people remember, but it's not all comers, or it's just hard to know?
Yeah. So we're definitely going down into the weeds of what intensivists talk about a lot.
Yeah.
Spent a lot of time over the last few years thinking about whether ARDS, and that's what this is, acute respiratory distress syndrome, whether there are essentially subtypes or subsets of ARDS. 15, 20 years ago, we were worried that there was an important subset of patients who somehow converted from an acute phase into a prolonged fibrotic phase. Then we began to realize we were actually causing some of this with the way we ventilated patients in the first place. Even when we had H1N1, we then started worrying, is there something unique about H1N1 causing where there's a virus-induced local disease, a kind of viral hemorrhagic alveolitis versus just a general host response? And then, of course, the question of secondary infection with bacterial pneumonia. With COVID-19, we're not getting too many reports. I've had a colleague from Wuhan who said anecdotally later on they're seeing quite a lot of bacterial secondary infections, but in most of the reports, too many people are talking about that. And as far as people talking about the unique characteristics of COVID-19, I've actually heard it both ways. I've heard. We've heard some stories saying, oh, we create a whole family of patients that are now not getting off the ventilator. And then there's other people who say, oh, we have a whole bunch of patients who, thank goodness we intubated them because they were incredibly hypoxic. But the good news was just 48 to 72 hours later, the hypoxia is gone. There's definitely stories emerging that there's more than one path once intubated. But I think we don't know enough yet. As you know, we're going to take a paper that's of about 1,500 patients from Milan. They are scrambling to get the data for us, but I think they would be the first to acknowledge, and we certainly acknowledge, we want far more data about those patients. It was amazing that they could even get as much data as they have, but I think we're all looking to try to understand more whether there are essentially maybe 2 or 3 different types of paths among the patients who get severe respiratory failure.
Case-fatality, once you're intubated, is high. From looking at the various reports, talking to your colleagues, do you have a sense of what it is?
So every series reports a higher mortality among the oldest. And that's almost certainly that one component of failing to survive is going to be some function of just older age, poor cardiorespiratory fitness, just an inability to withstand the ravages of acute respiratory failure and multisystem organ failure and all the requirement for organ support. So you'll probably always see a much higher mortality rate among older individuals. Beyond that sort of background, sort of human resilience that explains some of the variation, again, we're not seeing that much sort of secondary bacterial infection so far. So why are other people dying? It's a little unclear. It's not. We don't know enough yet about the course of viral shedding. We don't know whether there's a subset in whom there's just ongoing sort of severe viral-induced lung disease, or whether it is more just that even for a younger person, it is a lot to withstand multisystem organ failure. It's very hard all the organs talk to each other, and when they start to fail, they all unhook from each other. And then we crudely try to support each one. But moves made to try to optimize the lungs can be stressful for cardiovascular support. Then you try to do something for cardiovascular support and you worsen kidney injury. Now the patient has acute kidney injury, and the more these organ systems mount up, the harder it is to survive it. It's not a very satisfactory answer.
So we're going to go on to some of the clinical trial questions, and then end of life. But before we do that, I mean, Derek, you run a lot of ICUs. You're the director of a lot of ICUs. You have a lot of physicians who obviously are your colleagues and help. In the next few weeks, what's your greatest fear?
Well, I have to say, for our own institution, we haven't yet started to see the numbers really going crazy. We got a warning around the same time as New York, but New York already had more cases. And so we're like a lot of parts in the United States that maybe got a lead start on social distancing. So we're still prepared for a surge, but we're also thinking about what does a flattened curve look like? And that's months of operating under not an overwhelming caseload, but a huge caseload. Yeah. We're still struggling to have tests. Even now, every time a patient comes in, until they're diagnosed, or once they're diagnosed, they've already created in their wake a huge number of healthcare workers who now have to be self-quarantined. I think I'm worrying most about still thinking at the system level about how rapidly we can pivot to a smarter management strategy, where even if we are not having an overwhelming number of cases, it's not ruinous just to try to run a healthcare system even with a moderate number of cases, because the best option now is still horrendous.
Yeah, you can't, shutting down entire healthcare systems for 6 months to take care of only intensive care unit patients in the long run will have other consequences. So it sounds like what you're hoping is that you'll manage in the next month or 6 weeks and then sort out a different system of managing over the next 3, 4, 5 months so you can resume other types of important care that you provide.
Yeah, and anticipating the fatigue on people. It's like almost immediately being in some long, horrendous war. The metaphors in my mind are trench warfare from the First World War.
All right, so let's go to clinical trials. You and I have talked about it at length. I think there's more than 200 registered. So let's see. I would say I rejected all the viewpoints. I should have kept them of every drug that we should try, including one that just came to me as I walked in here, yet another one. But vitamin C, vitamin D, zinc, immunomodulators, antivirals, steroids, the new kid on the block, chloroquine. Do you want to say something about the clinical trials? And you and I have already talked, saying there's not likely a magic bullet, but let's put that aside. What's your sense of the clinical trials? Where will they be successful? Should they be tried in very sick people, or is the goal to try some of them in less sick people to prevent those people from needing the intensive care unit?
Okay, so you just set up that this podcast should go for about 4 hours. So as of yesterday, the COVID-19-trials.org website had 359 trials registered on it and counting. And the owner of that website knows that they don't have everything. So it's unbelievable how many trials are coming in. And many of my colleagues at other institutions around the country, just as in Pittsburgh, don't even know what to do. Do our IRBs approve them all? And then do we have everyone jumping on top of everyone to try to work out who should be enrolled in what? The problem, and the thing that I tried to talk about a little bit in the viewpoint, is that we actually have a shared or a joint goal. We absolutely have to take care of patients as well as we can. And how we're taking care of them right now is intolerable. And so we have to simultaneously learn as fast as possible to do our very best to know that the patient we take care of tomorrow, we can do so better than we did today. That tension to both take care of patients as well as possible and learn as fast as possible, that's actually an incredibly old tension that's been written about for decades in organizational science. It's known as the exploitation-exploration trade-off. The word exploitation sounds a bit pejorative, but they just mean by exploitation that you exploit what you know already. And exploring, you're taking a risk to try to find something new. You're testing something new. And the problem is that in every other walk of life, that's one joint problem with the same group of people or the same computer algorithm trying to actually optimize the ratio. What we've done in medicine, slightly by accident, though well-intended, is we gave the two problems to two separate organizations. The doing is all the hospitals and the clinicians and everyone involved in care. And then the learning are the universities and the NIH and the pharma companies. And both groups only have their own goal. And there's not enough people who are actually really trying to own both goals simultaneously. It's totally true all the time, but it has so come into focus with this epidemic. So, yes, someone who's trying to take care of a patient looks at someone who comes in with a clinical trial and says, pardon my French, you've got to be shitting me. Because no, I don't want to do 50-50 randomization. I don't want my patient to be a guinea pig. And no, I don't have time for all of this. We really need the clinical trial enterprise to try to think about designs that are much more accommodating to what clinicians are trying to do. Designs where hardly anyone gets usual care or control care. Designs that try to do essentially one-stop shopping. The clinical research enterprise doesn't have a clinical research czar. There's no single chief who has decided on worldwide prioritization. You tell me which of the 359 trials we should do first. So it's a bad time to learn it. But it turns out that we were almost, in a way, sitting on an organizational time bomb. We are not organized for truly fast, efficient learning while also taking care of patients at the same time.
Now, you're a world's expert in sepsis, and there's been no breakthroughs in terms of treatment. Mortality's gotten better, largely because of the remarkable work of the two societies in the U.S. and their guidelines. People really follow them. There's certainly been a reduction in mortality from general ARDS. Do you have a sense, is it going to be the antivirals? Is it going to be this so-called cytokine storm that we can intervene with? Will it be chloroquine? Do you have any, do your instincts tell you that there is something, there's going to be a big gain with one of these new therapies?
Yeah, so, the big gain will obviously be if the virus remains as a relatively consistent virus and doesn't end up merging with all coronae, with novel strains popping up every year, then the big gain is going to be vaccination. Right. It's probably just as plausible, though, that even with vaccines, it's probably going to be like flu. Right. In which case, even if we get, we could now just have a suite of coronae, just as we have a suite of flu, and then every so often we'll get a particularly virulent one. And under any scenario like that, then of course we'll be looking at trying to think about making little notches all the way across the care paradigm. So if you do have innocuous therapies that are adequately cheap and safe, that people can take over the counter all the time, then it would be great for early prophylaxis, treatment, pop a pill, even if you have a mild cold, etc. If they're a little bit more expensive, then they could maybe be tied to rapid diagnostic tests. It's just sort of a classic 101 of which therapies for which piece of the pie. But it's also quite possible that by the time people do get sick, at that point, modulating the course of viral replication may only play a relatively minor role. By the time the host immune response is ramped up, it's quite likely that we may well need to be thinking about manipulating both the host pathogen interaction around ACE2, thinking about suppressing in a favorable way downstream immunomodulation, and maybe doing so on background of some therapies that are at least keeping the virus in check. If you
so that would be a combination, an antiviral and something else.
And that would be in addition to then fine-tuning all of the supportive care. Maybe there is a better way to ventilate people. Some of the biggest trials in critical care in terms of their impact on mortality were just changing the size of the tidal volume on the ventilator. So actually, in my mind, it's a stacked approach, and you're trying to fine-tune every part of the entire engine, which again is why it's sort of it just seems there's almost hubris in thinking, oh no, I have the trial. I have the one drug that I'm going to test against placebo. And the reason you should do my trial is because no one else had as good an idea as me. I think we don't know. It's likely that we could make gains across the many things that we need to do right. You started by talking about surviving sepsis. I'm sorry, you wanted to jump in.
No. Go
Okay.
ahead. You finish the surviving sepsis. Go ahead.
There's 54 steps in the COVID-19 guidelines. And they admit that there's not good evidence around any of them. But there's already 54 things that they need to think about doing in the care of these patients. All of them could be fine-tuned.
Do you understand the exuberance around chloroquine? Comes up every day in my emails. We've talked about it before. I talked to other people around the country. I know the President Trump has talked about it, but some people are very concerned that there could be side effects that we don't know about. It really hasn't worked very well in any other condition like this. But do you have a sense of the exuberance? Is it that notion of trying to do when we know people are dying?
Yeah, I think so. The first thing I'm going to say, this thing's been around for ages.
Yeah.
I would say we, as in JAMA, but you and I weren't even born, published a paper on quinine as treatment for the Spanish flu in 1919. People have been thinking about the potential disease-modulating effects of these quinine-based antimalarials in viral infections forever. And so it always comes up. So the exuberance is in part because no one needed to lean back too far on their bookshelf to find the rationale. The drug is cheap, widely available, and it's plausible. How it caught the particular zeitgeist is unclear to me. There are a couple of other agents that have caught on like wildfire that have a little bit of a... You asked me about sepsis. We've been studying sepsis for decades. We have done hundreds of phase 3 trials. We never, and they were virtually all negative. We never did them testing agents that didn't sound like a good idea.
Right.
That everyone is a good idea. Everyone has a mouse study or an in vitro study or some plausible biologic rationale. Why some things catch on? Why does vitamin C catch on? Sometimes a story catches the imagination. I imagine it might well be because it does have that sense of, oh yes, there's a good rationale and it's really cheap and I have a ton of it sitting on my shelf here.
Okay. The focus on within the clinical trial registry of COVID-19, the focus on really ill patients versus more mildly ill patients. I've been talking to some people and they've suggested it would be nice to focus, there should be some focus on the less ill so you can prevent them from becoming ill. Are there any clinical trials in that area, or have most of them been really focused on the more ill patients? Yeah.
So I'm involved in one of these large international adaptive trials, and we have been thinking about, in order to to sort of bend towards having an overarching conceptual model of the disease for where you would give therapies when. Right. We've roughly divided in our minds the disease into sort of 3 symptomatic stages, and it's quite similar to what the WHO has done as well. There are those that might hit the hospital but are seen well enough to go home. We would call them mild. Those that hit the hospital, get admitted to the hospital, but don't yet require ICU care for respiratory failure, we would call them moderate. And then someone who arrives who's already hypoxic and likely needing to be intubated, we would call them severe. And you could imagine that different therapies would work differentially at different times. I'm not sure I would even want to try a powerful host immunomodulatory agent in anyone who wasn't already getting sort of infiltrates and evidence of ARDS. On the other hand, it's quite plausible that antivirals would work best if started sooner, but I wouldn't deny them from someone who was already sick. And so I would have a stratified analysis with it being plausible that an antiviral started later in the disease course may be less effective. You also talked about getting really early and getting into, for example, an outpatient setting. And I think that will be interesting. But right now, we're trying to not even have patients encounter their PCP. We're trying to have them phone up and manage their symptoms at home and trying to avoid, almost as a social isolation effort. And then only if they're sick do they go to the hospital. So right now, outpatient trials, if they involve a physician interacting directly with the patient, are likely only starting among the ED population to go home. But it really raises the issue of whether we could start to think creatively about moving out into the community and thinking about novel kinds of trial designs that don't involve the outpatient clinic and don't involve the ED. They interact with pharmacies and maybe through health plans, etc. Again, you need to know that the agent was pretty safe and it would probably have to be reasonably inexpensive. And you'd have to think about how you would get the person tested. It might be weird to think about large-scale use in a relatively uncontrolled setting of drugs for patients who might not even have COVID-19.
Yeah, the last description, I remember the first live stream I did with Tony Fauci, and we were talking about vaccine development. It was the same thing. You're giving it to generally healthy people. You have to make sure it's safe. Obviously, it has to be inexpensive. You want to, in this country, vaccinate 315 million people. And he said, he made it clear that that's why phase 1 to phase 2 to phase 3 to large scale deployment is so complicated for vaccines. Now, when we were on the live stream on Saturday, probably the most painful portion of it was hearing both the Italians and the French talk about how difficult it has become for families whose loved ones are in the hospital. Visitation is remarkably limited, and their loved ones are dying and are going to die. Either they're on a ventilator or they've been appropriately extubated to spend the last few hours in comfort. How do you imagine that playing out in the U.S.?
Yeah. So again, this has sort of different levels to it. So the first thing is working out that patients, even ahead of time, have worked out their advance directives. One can imagine different ways of end of life. And the worst would be situations where patients are under isolation, can't speak with the family members, and there's a sense of things left unsaid. So I think it was Gordon Rubenfeld had written a piece in the Toronto Globe and Mail saying, without meaning to be trite, if ever there was a good time to make sure you had completed your advance directives, now would be it. And I say it, we're both slightly smiling, but we mean it. I think we have, this disease has put in particular, all of our frail and elderly relatives potentially in harm's way at a dramatically increased risk of acute severe illness that will last for 3 to 5 years until we have effective vaccine. And we're a long way from having herd immunity. So this will be a scourge that we will live with in society for years. So the first thing would be to not skimp on thinking about every family trying to think about taking these conversations more seriously than we have perhaps in the past. Then for patients who nonetheless are now very sick but have found themselves in the ICU, and now everyone is scrambling to try to work out how to have appropriate end-of-life discussions in order to best understand, so the physicians can best understand from the family what the likely preferences are for that person. That was already hard in the best of time. I wouldn't stop any of the things that we've already been trying to promote. Trying to have better facilitated conversations, trying to have them early, where early is even in the waiting room in the ICU rather than sort of 2 to 3 weeks later. And then I think on top of trying to do all the things that we already want to happen, there, of course, is this added issue of, especially under the current crisis of lack of PPE, patients under isolation and no easy way to gown up and put everyone in the room together. In our own institution, we've already mounted donation campaigns for iPads. Every single end terminal that we have is being deployed for a massive expansion of telemedicine. So it's not like we had lots of tablets lying around that we weren't using already, but we totally are thinking about how can we create the equivalent of our podcast here? How can we create Skype or Zoom? Obviously, if the patient isn't communicating, that's tough. But there may be a way to at least make some of this more virtual. And then finally, I think it was Doug White mentioned to you in his podcast. I think there's a case to be made that of allowing family members to get extra PPE, etc., as a sort of compassionate use of PPE. In other words, most of the time, visitation is suppressed as an appropriate public health measure inside these cohorted units where everyone has COVID-19. But there has to be some moment where we might try to, under extenuating circumstances, still try to facilitate a moment where family members can be with their loved ones at the end of their life.
Yeah, I'm guardedly optimistic again because most of the cities in the U.S. have been able to understand what's happening in Europe and New York City and have gotten another few weeks to prepare, presumably before the surge. So that one, they've talked about developing telemedicine, particularly in the ICU, which is already technologically sophisticated, and iPads aren't that complicated. And then I'm hoping that in a few more weeks there will be enough PPE so that family members can visit when appropriate. I know it creates other complications, but Doug talked about the extraordinary times when patients are dying and the need to be with family. Family needs to be with the patient, and the patients need to be with families. I want to run through some of the questions. Okay. How soon do you think we'll get results from the randomized trials?
So there's one trial, the remdesivir trial, that's charging through. The NIAID remdesivir trial, I think, is more than halfway through. That's a several hundred patient trial, and that may well reach conclusion in a matter of weeks. Having said that, we should be prepared for the potential that the conclusion might be indeterminate. There's been one trial already of Kaletra that was indeterminate, essentially negative, but completely negative. We're not quite sure. It could well be the case that people will end up thinking, maybe the trial was slightly underpowered. Again, that's one of the problems with these fixed traditional designs, is that you sort of invent the sample size. It's a brand new disease. The adaptive trials will release answers to the individual questions as soon as they hit predetermined thresholds. So if anything has a moderate treatment effect on a lot of these event rates, sort of 15% improvement, et cetera, then some of those trials will yield positive answers with a few hundred patients enrolled. It's all about how rapidly these trials get ramped up. The REMAP-CAP trial is enrolling a patient every hour, even though many of the ICUs are actually in Australia and New Zealand, which hasn't even got the surge yet. So even just from their European sites, they're enrolling rapidly, and they're about to expand to many more sites. So I think what will happen, to long road to a short answer, I think we're a few weeks away from beginning to see the answer to the first of the few reasonably larger trials. And then I think we'll start to see quite a lot of trials producing answers. But that's already the summer into the fall.
Primary outcome in most of the trials?
Yeah, so there's 2 or 3 things kicking around. The WHO put out an 8-point ordinal scale. The number of things in the scale keeps changing, but it's like a weighted scale where you get most points for death, lower points for sort of all the way down to sort of like symptom relief, etc. So if your drug is moving across the spectrum of disease, you would notice it. And then there are traditional endpoints like mortality, or some of them are combined where they, for example, combine mortality with duration of time in the ICU. So if you never go to the ICU and you don't die, that's the best. If you don't die, but you spend several days in the ICU, that's worse. And if you die, that's the worst outcome.
Okay. It's a tough, difficult question. Would you use one ventilator for 2 patients? If ventilators are scarce? I know it's a difficult question.
I think for me, I don't think of it as an ethical question. It's only as a technical question. It is. There are issues, first of all, about. So if both patients have COVID-19, then of course you're not worried about one being affected by the other.
Yes.
But then there are issues of you have to synchronize people's breathing. They have 2 different compliances, so you need a relatively sophisticated adjuster. I'm hoping that that doesn't become a large-scale solution possible.
Okay. There's 1 million+ physicians in the U.S. Not that many are intensivists. I know you're getting help if you need it from anesthesiologists and ER docs, even hospitalists. What do you think the 900,000 physicians who aren't intensivists need to know?
Oh, that's not the question I thought you were going to ask. I thought you were going to ask what people are trying to do to staff ICUs.
Oh, well,
can I ask it reverse? Can I answer my own question?
Sure,
first?
answer your question and then mine.
So what people are doing is what was already alluded to in things like the Society of Critical Care Medicine guidelines and maybe in other professional society guidelines of using this triangled or tiered approach, where instead of an intensivist managing 12 to 15 patients, you scale the intensivists up to the top of a pyramid where they have as many as 100 ICU patients. And then they have, say, vascular surgeons doing all the procedures. And then they have a suite of endocrinologists, dermatologists, anyone who wants to be conscripted into this new ICU army, working underneath this one totally strung out intensivist. And now we, along with others, are trying to work out whether we can de-pyramid that solution with telemedicine. So you could have, if you need a warm body physician at the bedside, say in New York, and there's only one intensivist and 3 non-intensivists handling 100 patients, perhaps if we stand up very rapid telemedicine, then that endocrinologist or dermatologist could get many of his or her questions answered by a 24/7 standby intensivist. And certainly we're looking at trying to deploy that as fast as possible in New York. We've already been talking about a couple of systems in New York, and the lawyers and everyone are working dramatically to clear all the risk waivers, etc. And that might be a solution. And again, that's just for the immediate surge. But what does the long haul look like? We probably will need to think much more comprehensively about a coverage model that takes advantage of tele-ICU or telemedicine. What does the non-intensivist need to know? It depends on what they know already. I think for the non-intensivist caring for a patient who's not in a monitored or ICU setting, I think emergency medicine physicians and intensivists are finely tuned to the person who's going south. And I think that's probably the most important thing, is to make sure that someone doesn't get into respiratory failure and languishes too long. Since I'm not a non-intensivist, I just don't know how rusty people feel in their head about having that ability to sort of smell the pattern recognition that someone's getting into trouble. But that would be a lot of worry for us. And then I think because you can't intubate, I think managing rapidly worsening respiratory failure before someone else gets there, it would be good to work out in your hospital what's available. In your hospital, if you're doing, for example, in Britain, they do a lot of CPAP on the floor. It's not done on the floor as much in the US. But if you do CPAP on the floor, you should know how to attach a CPAP mask, or someone in your team should know how to do that and have a well-fitting mask and just have a smell for someone who's getting into trouble.
This is Howard Bachner, Editor-in-Chief of JAMA. I've been talking to a friend and a colleague. I hope people can realize that we have become good colleagues over the years. Derek Angus is the Distinguished Professor and Mitchell P. Fink Endowed Chair, Critical Care Medicine, University of Pittsburgh Medical Center, Professor and Chair of Critical Care Medicine. Derek, thanks for sharing your experience and your wisdom today.
Thank you, Howard.